Good morning. Thanks for joining us for part 2 of our webinar series. My name is Samantha, and I'm here this morning with Dr. Randi Brown, who's a naturopathic physician here at BETA Therapeutics. So today, I guess over the next 45 minutes, Dr. Brown is going to be talking about food allergies, food intolerances, and adverse food reactions. And there will be a question period at the end. So if anybody has any questions, we welcome you to just type them into your chat box, and then we'll take some time at the end to answer them. So I'll pass it over to Dr. Brown.
Hey everyone, I'm hoping everyone can see me and hear me okay. So welcome to the Allergy Diagnosis and Treatment Series. This is part 2. We did a prior series on environmental allergies and seasonal allergies and sublingual immunotherapy. So this is kind of the follow-up to that. So thank you for spending some time in your morning today to kind of learn with me some adverse food reactions and why I'm sort of so passionate about, educating people around these kind of common intolerances. So a brief introduction, I'm a licensed naturopathic physician. So first and foremost, I'm not an allergist. I'm a trained naturopathic doctor. I do have my pharmaceutical prescriptive authority, and that's my family there to the right. We love being outdoors and being active. And really why I want to talk to you guys today about adverse food reactions is because I'm really, really passionate about just general food and nutrition, as well as gastrointestinal health. And I love the intersection between the immune system with food allergies, intolerances, and sensitivities. So I hope I can keep you guys awake for the next about 30 minutes as we go through all of these different adverse food reactions. So quick medical disclaimer, the information on this webinar is intended for educational purposes only. It's not designated or designed to diagnose or treat any condition. You should always speak to your doctor before, applying any advice specifically found in this webinar. So I'm a doctor, I'm just not your doctor. Overview. This is the topics we're going to be going over today. We're going to start with food allergies, then allergy-mediated conditions like oral allergy syndrome, eczema. Then we're going to talk about food sensitivities, food intolerances, and then finish up with other adverse food reactions and really how that intersects with gut bacteria and the gut microbiome. So if there's kind of one page of this whole webinar, I can get you guys to take, a take-home message, it would be this one right here. So this is differentiating a true allergy from an adverse food reaction. So if we look at the very top of this chart, there's different types of adverse reactions to foods. So on the left-hand side, we're going to be looking at immune-mediated adverse food reactions. So on the far left-hand column there, we have food allergies. If we go down one more from that, we see that they're IgE-mediated. So that's an immunoglobulin E-mediated adverse reaction. So this is commonly like the peanut allergies, shellfish, and nut allergies. So these are severe systemic allergies. Next in the middle, we have the T-cell mediated. That's things like celiac disease, people that have severe autoimmune conditions to gluten, and as well as other sensitivities. And then we can go to the right-hand side when we're looking at food intolerances. These are non-immune mediated, and so they're very different types of adverse food reactions. They do not involve the immune system, and so these tend to be things that are either enzyme malfunctions or enzyme deficiencies. So I really, really commonly hear my patients say, I'm allergic to dairy. When they really mean that they have lactose intolerance and lactose malabsorption because they lack the enzyme to break down that sugar in milk that causes the localized GI symptoms like bloating, diarrhea, pain, and so on. And so it's just really important to differentiate, is this an immune mediated reaction or is it not? Because ultimately the severity of outcomes can be quite different and therefore they're treated very differently. So it's really important that we use the right language around these words because they mean very different things. So we're going to start off by talking about food allergies more in depth. So what are food allergies? The term food allergy really refers to an abnormal immune reaction to a food that results in the development of symptoms on exposure to that food. And it's usually quite rapid, the onset after exposure. The allergen is the substance that the body actually reacts to. So say a peanut would be considered an allergen if someone's allergic to that. So it's not like these allergens in and of themselves are harmful, it's that the body recognize them as foreign invaders and potentially harmful. And so the immune system tries to protect the body by creating, system-wide inflammation and immune regulation in terms of activating, systemic inflammation. So that's really where the problem lies. It's not like, the peanut itself is actually harmful. So if we look at food allergies in Canada, so a third of parents report adverse food reactions in their children. However, the bulk of these are actually non-immune in their kind of mechanism. So the peak prevalence is at 1 year of age. Many resolve in early childhood, though some do persist. So for example, peanut allergies is more likely to persist into adulthood versus egg, wheat, and dairy are more likely to resolve. And allergies can occur at any age, though only 15% of all food allergies are diagnosed as an adult. And it is notable that the older you are at the onset of your first allergic reaction, it can be more severe. So just keeping that in mind as well. And so if we look at sort of the increased prevalence of all types of allergies, so not just food allergies, but skin allergy and respiratory allergy, some resources say that there's been a trend in terms of increasing allergies kind of in North America. There's a lot of kind of hypotheses or reasons why we think this is happening. A major kind of accepted theory right now is the hygiene hypothesis, where, you know, we spend less time outdoors playing with dirt, we spend more time indoors, more sedentariness, we use antibiotics frequently and from a young age. We have less vitamin D and less natural sunlight exposure. And so all these things tend to disrupt the immune system. And one potential mechanism is by disrupting our healthy gut microbiome and really how we're developing that gut microbiome in that crucial window when our immune system is developing. So food allergies in Canada, again, children, the most common would be cow's milk, egg, wheat, peanut, and tree nut, which tend to coincide. And again, that started there because these ones are more likely to persist right through adulthood. And then for adults, it's more commonly oral allergy syndrome, which we're going to be talking about later, shellfish allergy, and peanut and tree nut, again, because you usually have developed that since a child. How do you know if you might have a food allergy? So your skin gets really itchy, flushed, and it gets really red, called hives or urticaria. It's swelling and you can start sweating. Your eyes get teary, swelly, and itchy. Your lungs and airways start to constrict and close up, which can cause sneezing, itching, choking, shortness of breath, and wheezing. The GI system also contracts, so that can cause nausea, vomiting, pain, and diarrhea. And then you can also get an overall sense of doom, faint, get dizzy, or even lose consciousness. So this is a medical emergency. This is it can be life-threatening, as we'll talk about in the next few slides. So it's important to be aware of these and to get, a rapid diagnosis after something like this happens. So this is the actual process of an immune allergy reaction. So if we start on the left here, we see antigen. So again, antigen, let's say that that's a peanut antigen that comes into your body. The IgE-mediated immunoglobulins are going to bind that antigen so that your immune system can deal with it, essentially. So it's tagging it so that your body can do something about it because this is a foreign invader that it thinks is harmful. So that complex then binds to what we call a mast cell. So that's that kind of blob in the middle of the screen. When that binding happens, there's going to be a release of pro-inflammatory mediators. So things like histamine and other prostaglandins, that ultimately the effect is vasodilation of blood vessels, so opening and leakiness of your blood vessels, which can cause that reddening or that urticaria and hives on your skin. The mucus secretion and contraction of your airways, so that causes the difficulty breathing, wheezing, and as well, it can contract the GI system. So that's when you get the nausea, vomiting. You can have elevated heart rate with low blood pressure, and ultimately increased pain response and loss of consciousness are kind of the results of these histamine and other inflammatory mediators as a result of the antigen exposure. So anaphylaxis is a severe allergic reaction. Again, it's quick onset after exposure, so it can happen, it can be life-threatening within minutes upon exposure. It's very severe, systemic, generally involves the skin and the airways. So we typically see hives, itching, redness, swelling of the lips, mouth, or throat, difficulty breathing, wheezing, and poor oxygenation. But it can also cause severe low blood pressure, loss of consciousness, vomiting, diarrhea, cramping, etc. So again, this is a medical emergency, and it's important to be able to recognize these and provide rapid treatment and medical assessment because again, it's life-threatening. So this is the epinephrine, EpiPen. So this is what we give in an anaphylactic episode. So EpiPen is just an auto-injectable epinephrine. So every child that has a confirmed allergy is going to be given at least one EpiPen to have on hand, and basically an emergency action plan. So you're always going to call 911. You're always going to follow up with a medical physician for assessment because there is some rebound allergic reaction. So even if you've administered Epi and everything seems fine, you definitely want to be monitored for at least 24 to 48 hours. So moving on to oral allergy syndrome, or OAS. So this is a kind of a funny allergy that's particularly common in adults. It occurs in people that have pollen allergies. Even though you might actually not exhibit seasonal allergy symptoms, you can still have oral allergy syndrome. So the symptoms include itching or mild swelling of the throat immediately following ingestion of certain uncooked fruits and raw vegetables. So basically the symptoms result from contact urticaria in the oropharynx, which is basically lips, mouth, throat area that's caused by a pollen-related protein in these foods. So they're kind of renaming or restructuring oral allergy syndrome to pollen food allergy syndrome, which is a little more descriptive of what's happening and how that cross-reaction can affect oral tolerance. So here's just a good picture of the cross-reactivity patterns in oral allergy syndrome. So we see that if you're, say, in the springtime, you notice you have seasonal allergies to tree, specifically birch, you might get oral allergy syndrome to things like apple, peach, plums, and pears, cherries, etc. And then weed is a little bit different. So it might be cantaloupe, honeydew, watermelon, and then same with grass with the addition of tomato and white potato as well. And so these are different families essentially of the fruits and vegetables. So again, just cross-reactivity of the proteins in the pollens and the proteins in these fruit and vegetables as well. There's also latex food allergy syndrome, which is natural rubber latex cross-reactivity with certain foods. The most common ones I see is avocado and banana cross-reacting with latex. So oral allergy syndrome, important things to note is that non-plant foods like cow's milk, egg, or seafood do not cause oral allergy syndrome, and a more severe allergy should be evaluated. So never assume it's oral allergies without first ruling out a more severe, potentially developing kind of anaphylactic allergies. It affects 5% of the population, though a greater proportion, up to 24 to 93% of seasonal allergy patients will have oral allergy syndrome. And it's most common in birch tree pollen allergic people, as well as polysensitized patients. So having multiple pollen allergies increases your likelihood of developing this, and having moderate to severe seasonal allergy symptoms as well. And lastly, living in an area with higher pollen counts. So here in Victoria, that's us. So we definitely see a lot of oral allergy syndrome patients here in our area. I also hear a lot from patients, they're very confused about their oral allergy symptoms and that they get them sometimes and that they won't other times, so they can't quite pick up what's going on. Well, on the left, this kind of explains why symptoms and reactions may vary. They can vary based on the variety of fruit, the source of the fruit, time of harvesting, and even the shelf life. Seasonal variations in pollens. So maybe in the winter, you can eat an apple or pear and be fine, but in the springtime when you're at peak tree pollen season, you might not be able to eat a pear or apple without getting your oral allergy symptoms. Impact of cooking. So again, this applies to only fruits and vegetables. So cooking it might destroy the proteins and then it's fine. So eating an apple pie would be different than eating a raw apple. And then peels versus pulps. And then in terms of your sort of GI health, increasing adverse reactions would be large amounts of raw food on an empty stomach, having low stomach acid or hypochlorhydria, or taking something like a proton pump inhibitor can increase your chances of having a more severe reaction. Because again, the acidity in your stomach tries to destroy those proteins. So if they're not getting destroyed, there's more of those proteins getting into your system. NSAIDs, intestinal hyperpermeability or leaky gut, which allows, again, those proteins to get into your system at a higher rate. And then certain foods are actually considered high risk. So if you get oral allergy symptoms to peanuts, tree nuts, and mustard, and possibly peaches, there actually is a greater risk that you can develop a more severe allergy or something, even anaphylactic type reactions. So something to be mindful of and have a really good conversation with an allergist about those high risk foods. So atopic dermatitis, aka eczema, I wanted to bring this into the conversation because there are IgE-mediated sort of exacerbations of eczema, but they're complicated. So I just wanted to go over those briefly. So atopic dermatitis is a chronic inflammatory skin condition. They call it the itch that rashes. So food-associated exacerbations and concomitant IgE-mediated food allergies are complex and they really vary greatly. Patients with atopic dermatitis have higher rates of allergic diseases, and up to 80% of children with eczema develop asthma or allergic rhinitis later in childhood. So we call this the atopic march, in which a child may start out by developing eczema, have food allergies, and then later in life, it turns into asthma and allergic rhinitis or seasonal allergies. The earlier onset and more severe eczema is associated with high egg, milk, and or peanut specific IgE. And in general, eczema is associated with elevated levels of IgE antibodies. And so this is relevant. We'll talk about this later in testing as well. So eczema and food reactions. Atopic dermatitis is considered the major risk factor for developing food allergies. There's a running theory that cutaneous sensitization through a disrupt skin barrier, so leaky skin, leads to food sensitization and food allergy development. So infants and young children with eczema are commonly sensitized to foods, including wheat, egg, and cow milk. And children over 5 and adults are commonly sensitized to aeroallergens like house dust mite. So one way to kind of prevent food allergies and decrease the sensitization is to keep the skin moist and protected to avoid food allergy development later in life. Some children and adults may have food exacerbations, and the more severe eczema you have, the more likely food may be playing a role in your clinical symptoms. When we talked about elevated IgE antibodies happening in eczema alone, so you can have these to a specific food, but it might not actually be a clinical reaction. So we call this sensitization without clinical provocation, meaning you can have an elevated IgE antibody to a specific food, say cow milk, but it doesn't actually change your disease or your eczema at all. And there are also non-IgE mediated food exacerbations of eczema, so things that we can't even necessarily test for. And so really what I try to do with patients is do the testing, use that as a starting point, and then ultimately that will guide an elimination and challenge diet that's a little better informed. And a take-home message is that IgE testing may be helpful as a place to start, but ultimately controlled elimination is the gold standard for eczema because it is a really complicated reaction. So the dried blood spot testing for IgE-mediated food allergies. So this is the AllerDetect test. It's one of the most comprehensive allergy tests available. It's designed to complement a formal allergy diagnosis. So we look at 3 main markers in the blood. The IgE, again, that's looking at true allergy, plus IgG4, which is the exposure information, tolerance, if you will, and the C3D marker, and it's used to evaluate non-IgE mediated reactions. This is what the testing process actually looks like. So it's just a single finger prick test, so there's no blood draw required. On the right-hand side there, you can see the blood, dried blood cart. So really 5 to 10 drops of blood is really all we need, about 5 to 10 minutes in office to actually do the test collection. So it's great for needle phobics. So non-invasive method for confirming allergies. The pros is that almost anyone can be a candidate for this type of testing because it is non-invasive. It provides accurate qualitative results. There's no histamine reaction. So I'm not an allergist, so I don't do food skin prick testing in my practice. But if you did do the skin prick testing, you would get a histamine reaction for a positive result, which can cause itching, irritation, even pain. It's quick, no blood draw required, generally doesn't require stopping any medications, again, unlike the skin prick testing, and more allergens can be tested at one time. The major setbacks would be that it is generally more expensive and it's slower to get the results. So these are the different panels. There's 3 different panels. These are all the foods that we test for in the blood. And again, each of these markers have the IgE, IgG, and C3D markers that go along with them. This is what the report itself actually looks like. So on the left-hand side, we're looking at IgE classes. So again, negative being healthy immune response, very high, meaning you have higher likelihood of allergic response to that food, versus on the right, that's going to be your IgG4 or your blocking potential. So that's more of the healthy immune response that we want to see kind of offset any IgE levels. So just briefly, the differences between IgE and IgG. So these are both immunoglobulins. So they're both immune markers that bind antigens. IgE is rapid. It's brief. So it also, as fast as it escalates, it de-escalates. The mechanism is binding mast cells, like that main mechanism at the beginning we went over, releasing histamine and inflammatory mediators. Quantity of food that's required to cause the reaction is tiny. So it's kind of an all or none reaction. Food can be any. Patient awareness, you almost always know, because again, it's so quick after ingestion or exposure to something that it's pretty easy to pick up the pattern. And persistence is lifelong and can disappear in some. Versus IgE tends to be a delayed, prolonged reaction. Its mechanism is different. It's very dose dependent. So as you eat more of that food, your IgG levels will go up. We see them most commonly in common foods that you eat. Awareness is quite variable as well, and they last a lot longer in your blood. So why is testing allergies important? So it supports a diagnosis. Symptoms of allergies don't always mean it's a true allergy. And again, I see this a lot in my patients that think they have allergies to a certain food and we check it and they don't. And so there can be, a different treatment plan thereafter, which is quite helpful. Identifies the specific allergens, which is essential for allergen avoidance measures, and it's necessary for allergen-specific treatments as well. And really, there's a huge educational value in it that if you can kind of understand and gain some knowledge regarding your allergy awareness, you can have better treatment outcomes. So now we're going to dive into non-IgE mediated food reactions. So we're going to look at IgG-based food sensitivities and food intolerances. The food sensitivity testing, the IgG-based testing, specific food associations of IgG antibodies are detectable in the blood. So this is not a true allergy. It's non-IgE mediated, so it's not that severe systemic rapid onset kind of allergy that we see. So again, it's delayed. The theory is that potentially considered a type 3 hypersensitivity. What this means is that some are theorizing that the antibodies form complexes with the antigen, so the food protein, and deposit in blood vessel walls where they can cause tissue damage. So the IgG1 and IgG3 can activate the complement cascade, which is basically a way of starting systemic inflammation. So what this clinical studies have shown so far is that IgG-based food eliminations provide benefit for people with migraines, Crohn's disease, and IBS. So I just want to make it very clear that when we're doing IgG-based testing, we're talking less about food allergies, less about the immune system, as more so these chronic, low-grade kind of inflammatory conditions. Here's just the pathway that I'm talking about. It's a little bit scientific, but if we just focus on the left-hand side where it says classical pathway, we see those immunoglobulins 1 and 3, as long as with the food antigen. And then down the line, we see that C3d marker and the activation of that whole inflammatory cascade. So why do these IgG-based markers for food show up in the blood? So it's normal for about 15% of consumed protein to be incompletely digested in the GI tract, including a portion of food allergens. So a certain amount of food antigens, which are not destroyed by digestive enzymes, bile salts, your gastric pH, may penetrate the epithelium of the digestive tract and actually reach the body's internal environment, so your blood. Factors that may increase food-specific IgG antibody levels include repeated exposure to a food, increased intestinal inflammation and hyperpermeability, aka a leaky gut, and improper digestion and breakdown of food proteins by the acid, enzymes, and bile salts. And so although the clinical utility of IgG-based testing is still uncertain, there are some studies that suggest it may be beneficial for IBS, IBD, and migraine patients, though we do need more study to confirm this. So this is sort of the interaction with the gut ecology or the gut microbiome, basically that bacteria composition of one's gut and how this kind of comes into play with adverse food reactions. So if we start by looking at the left-hand side of the picture, we can see that steady state. First, I want you to look at the cells. They're nice and tight together, so there's not anything kind of leaking through that barrier, as compared to the right-hand side when that's more of a pathologic state or a dysbiotic state. Your gut has lots of inflammation, the intestinal cells become leaky, and so you can see those proteins are coming through those gaps in the intestinal barrier. As well, there's a lot more inflammation in that gut, as you can see those cytokines like IL-12, IL-13, et cetera, being secreted from those intestinal cells because of the environment that the gut's basically in. That can cause the immune system to be a little hyperreactive, which causes, has a role to play in celiac disease and food allergies, as you can see in the bottom, versus that kind of steady or healthy gut microbiome state, which helps the immune system build tolerance to foods by creating an anti-inflammatory environment. So food proteins, the gut microbiome, and the immune system, how do they all interplay? Basically, pathogenic bacteria or opportunistic bacteria can increase intestinal permeability, leaky gut. They promote inflammation and immune dysregulation. They can increase the allergenicity of food proteins. So if a bacteria basically digests a food protein before our body gets the chance, it can change how our immune system might react to that protein because it looks a little different now because something else has kind of pre-digested it. Disrupts digestion and absorption of carbohydrates and proteins. So I commonly see carbohydrate malabsorption, essentially like bloating, gas, diarrhea, and a lot of this can be due to the gut microbiome and that interplay. And as well, it can reduce the beneficial or protective flora. So it kind of becomes a vicious cycle if we have some opportunistic bacteria that then the good microbes can't get back in there to colonize and sort of dampen down the immune system response and heal the gut barrier. This is just like where the kind of research is going in kind of getting ready for this presentation. I really wanted to look at what, where does the gut microbes come in? And I was quite shocked to see the amount of literature out there and how much it's an exploding area of research right now. Basically from anything like development of celiac disease to food allergies to influencing just like food sensitivities and adverse food reactions. So I think your gut microbiome and the composition of your gut bacteria is really a vital role in how you handle food antigens and just how your digestive system really functions altogether. So I think it should definitely be a part of that conversation and should be considered and looked at in evaluation as well. So just briefly, I want to mention food intolerances and other adverse food reactions. So these are completely non-immune mediated food reactions. So they make up the majority of adverse food reactions. They're an abnormal physiological response that's not triggered by the immune system. Could be physiologic, neurogenic, or enzyme deficient. There's many different categories and mechanisms of these adverse food reactions. So I just kind of listed the most common ones here. So again, enzyme deficiencies, if we think back to that flow chart that we started with, this would be on the right-hand side of that chart with the non-immune mediated reactions. So enzyme deficient being lactose intolerance is really common, as is carbohydrate malabsorption. So again, that's that person that when they eat dairy, instead of getting anaphylaxis or severe allergic symptoms, they just get bloating, GI discomfort, and diarrhea due to that sugar hanging around in their intestine and causing some problems. FODMAPs intolerance is really common, which are basically just fermentable carbohydrates. See that commonly in IBS, SIBO, and bacterial dysbioses. Salicylate intolerance, quite common. Biogenic amines is one that we know are headache triggers, migraines, and they even have medication interactions. So there's some kind of pharmacologic interactions with nutrition, which I find very interesting. Sulfite sensitivities, asthma hives, wheezing, and MSG is known to cause headaches as well as chronic non-allergic rhinitis. So I just wanted to mention these to kind of open up that other side that we looked at in that flow chart, in that adverse food reactions, they're very complex, and there's a division with immune mediated and non-immune mediated. And non-immune mediated, there's multiple different categories and mechanisms to consider there. So just sort of a top level summary of everything that we've gone through is that adverse food reactions are extremely common and they're very complex. Food allergies are IgE mediated and tend to be very quick in onset and very severe. So testing and clinically evaluating IgE-based allergies is really important. And you should also be aware that there are false positive and false negatives with testing. So clinical evaluation is key. Really, if you suspect food allergies, you should always be following up with an allergist. And non-IgE based adverse food reactions can be considered as either toxic, psychosomatic, or specific intolerances. So enzymes or food breakdown. And sometimes it can be less about the food than it is about digestive health, microbiome composition, medication use, and other psychological factors that impact our overall health. So again, as a naturopathic doctor, I try to really zoom out my focus sometimes and figure out what else is happening in the context of this adverse food reaction, and then start kind of peeling back the layers of the onion to figure out what's going on. And that's definitely guided by any testing and treatment evaluation, but more importantly, sitting down with the patient, getting to know their signs and symptoms, and figuring out kind of where to start and if the labs match their symptoms, and really kind of taking those two together and working out a treatment plan. So that's basically all I have for you today. Thanks again for listening in this morning. I have my references here at the end. They're all broken down into the categories that we went over. So if you're curious or want to know more, they're all here. But I will basically leave you with this page, and then I'm happy to answer any questions that anyone has.
That's great, Randi. Thanks so much. The references, I guess I should point out, if anyone does want to look at them, we will be sending out an email with a link to this webinar, so you have any of the information to go over for all participants for today. So you'll have that. We do have a couple of questions here. Okay, so the first question, if my son turns out to have a true allergy to peanuts, can you provide a letter of confirmation that I can present to his school and have him carry along with his EpiPen? And actually, this is a two-part question. And then they also want to know how many EpiPens should they have on hand?
Yeah, so anyone with a suspected true allergy or a history of anaphylaxis, so again, that life-threatening medical condition, you should definitely be seeking an allergist consultation, so seeing that specialist. And you should always have an emergency action plan on hand. So that means your child being equipped with an EpiPen, having an emergency action plan that multiple staff are aware of, and multiple staff in the school or daycare know the location of the EpiPen, just in case someone's away or sick. They definitely have a backup where they can access that. So it's definitely something that you should work with a physician on, including an allergist being a part of that conversation. And in terms of number of EpiPens, generally recommended to have 2 on hand because we want to administer epinephrine every 10 to 15 minutes, depending on the severity of the reaction. So even more important if you know it might take a while, say 30 minutes, you're out camping to actually get into a medical center. It's important to know that you have enough epinephrine on hand to potentially save a life. But that's also something that you should talk to your doctor specifically about what you need.
Okay, the next question is, if I have a birch pollen allergy, will treating the allergy with shots or drops help with the associated food allergies?
Yeah, so there's growing research in this area. Right now, it's relatively inconclusive whether or not doing the immunotherapy will improve oral allergy syndrome. It's not a labeled indication at this point. That being said, if you have really bad birch tree seasonal allergies anyways and have considered sublingual immunotherapy for the treatment of your seasonal allergies, then there's a chance that it might help with your oral allergy symptoms as well.
Okay, the next question. I had a blood sample allergy testing before, and they said that I was allergic to around 30 different foods. I know that I can eat some of them without a problem. Should I be retested with the AllerDetect test? And can I compare your test with my previous test results?
So yeah, short answer is yes, you can definitely compare results. Again, we have to be careful of the wording. So it's likely that you were given an IgG-based test, which again, as we talked about, is not a true allergy. That would be a sensitivity. And so the problem with that is that there can be false positives. So ultimately, when we're looking at non-allergy, non-IgE mediated reactions, that's when we want to ultimately do an elimination and challenge diet that's guided with a practitioner to kind of get you through that, to really figure out what your true adverse food reactions are. And so, again, testing or retesting can definitely be a part of that.
Okay. Next question is, I would really like for my GP to okay the testing before I have it done. Do you have information that I can share with him?
Yeah, absolutely. We can kind of forward any information that they might be interested in. And my goal is to really work collaboratively with other healthcare professionals. So again, it's keeping that communication open and yeah.
Okay, perfect. Looks like 2 more questions. CBC Marketplace did an expose on IgG testing done at a couple of the major labs in Canada. How is your test different?
So the AllerDetect test is different because it's running 3 separate markers. You're looking at the IgE, which is actual allergy marker. It's running the IgG4, which is your protective or exposure marker. And then the C3D marker is ultimately, like in that cascade that we looked at, is sort of that initial immune trigger for potential food sensitivity, again, ultimately guided with elimination and challenge. So it's a different form of testing than the other ones that were mentioned in the past.
And can a peanut, we have another couple questions, sorry. Let's take a look here. Can food allergies cause acne?
Food allergies cause acne? Generally, no. That could be something different. So we look at perioral dermatitis, which is a different condition. It can be immune mediated, or there actually can be natural histamine or other kind of aggravants in foods that are just naturally occurring in those foods, that if you get acne specifically, around your mouth, that can be an indication that you're having some sort of hypersensitivity reaction, but it's not necessarily a food allergy. more of like a contact irritant kind of situation. But again, it would be good to actually get that assessed, just to figure out, again, what's going on, and potential food triggers that you can relate to that.
And is that something that you can assess in your practice?
Yeah, definitely. It's something that I see quite commonly in my practice.
Okay. Looks like, let's see, last question. Can a peanut allergy be cured?
Peanut allergy. So yes, just not by me. You definitely have to see an allergist. There's ongoing research on oral immunotherapy for food. So kind of desensitization therapy with really low doses of the antigen like peanut, and developing tolerance over time. Again, that's beyond my scope of practice. So that would be something that you would be consulting an allergist or a specialist for.
Okay, perfect. So if there are any last minute questions, I guess I would urge you to get them in the next minute or so. But other than that, yeah, we just thank you for your time, and sort of Dr. Brown, thank you very much for putting this together. It was really informative. And then thanks to all the participants as well for learning a bit more about some of the services that we offer. And we'd also encourage any of the participants who came in today, you're welcome to, call the clinic if you feel like you have been, like if not all of your questions are answered, or if you wanted to have another chat. We do offer a 15-minute free consultation with Dr. Brown, and then you can see if a consultation and the testing is maybe what would really benefit your healthcare at this time. So yeah, thanks very much.